Welcome everyone. We'll get started in just a few moments. In the meantime, please write in the chat box who you are and where you're joining us from. And please also take this time to select your language. You can select your language by clicking on the globe icon at the bottom of the Zoom screen, and it will take you to the English or French channel. You can then choose to mute the original audio. You may also select whether or not you'd like to read captions during the session. You should be seeing these captions automatically, but if not, you can select them by clicking on the icon with the two C's at the bottom of the Zoom screen. And if you wish to hide the captions later, please select the same icon again and select Hide Subtitle from the menu that appears. These captions are generated using an automatic feature in Zoom and therefore may not be 100% accurate. On the Zoom platform, captions are only available in English at this time. We've also shared a few poll questions that we encourage you to respond to while we wait for others to join us. If you'd like to read these questions in French, the French translation has been added to the chat box. And as you'll note, the questions are on the slide in both English and French. The answer choices are in both English and French in the poll. So please take a few moments to share who you are and where you're joining us from in the chat. Select your language, select if you'd like to continue to read captions, and respond to the poll questions while we wait for others to join us. We'll get started in just a few moments. Thank you again for joining today. I want to welcome everyone again to today's session. My name is Brittany Getch, and I'm a program officer on the Knowledge Success Project at Johns Hopkins Center for Communication Programs. Knowledge Success is excited to be partnering with FP2030 on this series. This is our 16th conversation in the Connecting Conversations series. And if you've missed previous conversations, you can watch the recordings on FP2030's YouTube channel or read blog post recaps that include recording links on the Knowledge Success site and get up to speed. This conversation will last for approximately an hour, and we'll have an open Q&A discussion with our three speakers. It's being simultaneously interpreted into French, as I mentioned, and it's being recorded in both English and French. The recording will be available in the coming days. If you haven't already done so, please select your language by clicking the globe icon at the bottom of the Zoom screen, and it will take you to the English or French channel. A reminder about closed captioning, you can also select whether or not you'd like to continue to read captions during the session. You should be seeing these automatically, but if not, you can select them by clicking on the icon with two C's at the bottom of the Zoom screen. To hide them later, select the same icon again and select Hide Subtitle from the menu that appears. Participants are muted throughout the duration of this conversation, but if you have questions for our speakers, please type them in the chat box as you follow along. My Knowledge Success and FP2030 colleagues will be moderating the chat box and will get to as many questions as time allows. Just a little bit about this Connecting Conversations series in case you're joining us for the first time. Connecting Conversations is a series of discussions on adolescent and youth reproductive health hosted by FP2030 and Knowledge SUCCESS. Through the end of this year, we'll be co-hosting these sessions every few weeks on a variety of topics. The series has been divided into 5 themes. We began with a look at a foundational understanding of adolescent development and health, and we continued our conversation by exploring engaging critical influencers to improve young people's reproductive health, and our 3rd theme focused on adolescent responses services. We're excited to continue this set of conversations on key youth populations with a discussion on young people living in humanitarian settings and ensuring their SRH needs are being met. Before I introduce today's moderator, I want to begin by looking at the poll answers. So if we could bring those up. Great. The first question, does your country collect data on the SRH needs of displaced young people, internally displaced refugees or asylum seekers? And it looks like the majority of you, well, almost evenly split, said yes or not sure. The second question, does your country's health strategy include emergency preparedness and responses for SRH, including family planning? And the majority of you selected yes. These are just 2 of the many things that our speakers will touch on today, and I want to thank you for answering the poll questions. Now, I'm pleased to introduce our moderator for today's conversation. Anushka Kalyampur is CARE's lead for sexual and reproductive health in emergencies. She is responsible for ensuring quality technical and strategic support across the organization, including through technical management of CARE's sexual and reproductive health and rights in emergencies, surge deployment, and response efforts. Anushka works within CARE's humanitarian architecture to strengthen SRHR integration across sectors, with a special focus on gender and emergencies to ensure CARE's SRHR responses are people-centered and gender-sensitive. Anushka also plays an active role on the Interagency Working Group, IAWG, for SRH in crisis settings, and co-chairs their adolescent sub-working group. Anushka is a graduate of Columbia University's Mailman School of Public Health and Georgetown University's School of Foreign Service. Anushka has worked in the sexual and reproductive health and rights in emergencies space for over a decade, specifically at CARE for the last 4 years. Welcome, Anushka, over to you.
Thank you so much, Brittany. And thank you to all the participants for joining us today. It is my pleasure to introduce the fantastic panel we have lined up today. So first I'll start with Dr. Alka Baru. Dr. Alka has a medical degree from the Government Medical College at Nagpur University in India. She has a PhD in sociology and has worked for the past 15 years on research, specifically on monitoring and documentation of best practices related to reproductive health initiatives and programming, including adolescent SRH, maternal health, health systems, and gender. Currently, she's working on monitoring and documentation of progress in case studies related to the Learning District Initiative of India's National Adolescent Health Program, which includes adolescent maternal health and nutrition for the World Health Organization. She also currently serves as a steering committee member of Common Health. Welcome, Dr. Alka. Second, we have Vaitar Muraji Araruma, who is the executive director at Kigali Hope Organization, with more than a decade of experience working with vulnerable young people, especially young people living with HIV in Rwanda. Kigali Hope Organization is a youth civil society organization whose mission is to reduce HIV infections and improve the lives of young people living with HIV. Outside of work, Vaitar enjoys the company of his family, but also enjoys sports with special interest in running outside on the beautiful streets of Kigali, Rwanda. Welcome, Vaitar. Finally, we have Eric Bernardo. Eric is a registered nurse by profession who chose not to confine himself within the conventional four corners of a hospital. After his medical career, he actually in 2013, together with other colleagues in the nursing profession, formed the Philippine Society of Nurses, of SRH nurses, sexual reproductive health nurses, which is a non-stock, non-profit professional regulatory board of nursing certified specialty organization of nurses, advancing the practice of sexual and reproductive health nursing in the country. He currently holds the position of president until 2022. At present, he is the Adolescent Sexual Reproductive Health Program Coordinator and HIV focal point of the Khan Center for Women's Health, another nonprofit focusing on women's health and adolescent health. He also is currently working as the Family Planning 2030 Youth Focal Point for the Philippines. He holds a bachelor's degree in nursing and a master's of arts in nursing in disaster and emergency management. So an excellent lineup of speakers today. Welcome, everyone. So as you heard from Brittany, today we will be focused on adolescent and youth SRH, sexual reproductive health in crisis settings. So to start us off, my first question for the panelists is, one, according to UNHCR, 82.4 million people were forcibly displaced at the end of 2020. When we think of humanitarian settings, what are we talking about from your perspective? Over to you, speakers. Please jump in.
Hi Anushka, thank you so much for having me. If I may start. Well, the Philippines lies in the Pacific Ring of Fire, and we usually being visited by quite a number of typhoons annually. We also have a number of earthquakes and volcanic eruptions and all that. So for me, when we talk about people living in humanitarian settings, we talk about those affected by natural disasters and calamities. We talk about those affected by man-made conditions, for example, say terrorism and all that. So yeah.
Great, thank you so much, Eric. Would anyone else like to add to that?
Well, if I may add a little about, but in India, we do not have such crisis situations as have been seen in other countries in terms of natural disasters. But we did have in the recent past problems of internal displacement because of the lockdown and which was imposed without prior notice. And those crisis situations have implications for young people and adolescents, and have similar implications as any other natural disaster or crisis has.
Thank you, Dr. Alka. Fighter, anything to add from your end?
Yeah, thank you. In Rwanda, when talk about these groups of people who are not living in their homes, we think about because in the region, in the Central Africa region, there is many wars in that region. So people have been displaced because of those wars. So we have many camps in Rwanda. So there are people coming from DRC, that is Democratic Republic of Congo, and Burundi. Those are neighboring countries for Rwanda. So in those camps, there's many young people, but also there's an urgent need of addressing problems of sexual and reproductive health in those camps. Thank you.
Great, thank you so much, speakers. Yes, so to summarize, as we heard from Eric, It could be humanitarian crises, could be man-made, they could be natural. We've all been facing not just epidemics, but actually a pandemic in the last year, which has overlapped and overlaid existing humanitarian crises. So people who are already on the move or forcibly displaced due to crisis have been further impacted. So thank you for that and for getting us started. Great. So maybe, given the focus of our discussion today, perhaps we can now, maybe hear from the speakers. From your perspective, what are the needs or the challenges of young people living in humanitarian settings related to their sexual reproductive health? Dr. Alka, I think you started to speak about that. So why don't we start with you?
I'll speak. My experience is largely limited to my own country, so I talk about those challenges. In addition to the known challenges and the health needs that young people face during this specific pandemic, which led to the humanitarian crisis, we had additional challenges because the schools were closed, there was no social interaction. So the adolescents particularly were stressed, had anxiety, depression. So a lot of emerging mental health issues came up. And they had no one to share their needs and challenges with, because the community level frontline workers were all focused on pandemic, and there was nobody to listen to them or address their needs. The family circumstances also changed because there was job loss, lack of economic opportunities, there was increased gender-based violence at household level. All this added to the stress, and the major issue which is coming up is rather gender violence and of course mental health issues. Those are coming up rather than sexual and reproductive health issues alone in India. Thank you.
Dr. Alka. Eric Viter, would you like to add to that?
Yeah, same as Dr. Alka, I can speak for what's happening in the Philippines. Prior to the pandemic, the Philippines holds one of the record of having one of the highest cases of teenage pregnancies. And this pandemic, as you've mentioned, Anushka, that we're in the middle of a we're having lockdowns since March of last year, and we're seeing now quite a number of teen pregnancies continues to be on the rise. In a recent report, as of 2019, cases of teen pregnancies for among 15 to 24 are quite declining, but unfortunately we're seeing the numbers increasing for those 10 to 14 years old. And not only that, we also have quite a problem in terms of HIV among young people 15 to 24. And with this pandemic that we're currently in right now, so young people are restricted from going out for both essential and non-essential reasons. And we're fearing that they can't get themselves tested. They can't, those who are living with HIV, they can't go to their treatment hubs for them to get refills of antiretroviral medicines and all that. And we're also seeing, although it's not seen in the reports, but we're knowing that we're noting some underreporting in terms of gender-based violence. And as we all know, if you're in a lockdown with your perpetrator, then definitely you can be at a loss of where to report if you can't get out of your home, for example. Thank you.
Thank you, Eric. Viter, over to you.
Yeah, thank you. In response to your question, in humanitarian settings in Rwanda, there's a problem, especially because of it's a refugee camp. Those refugee camps, there's a lack of basic facilities like health centers, but also a youth centers where they can go and learn and have also some services related to sexual reproductive health. But also there's, in those camps, there's also a problem of trained people who can help to educate young people in those refugee camps. But also compared to other people around the camp need like schools where young people can also learn other information, like when they can go and learn like basic education, because that also can also help empower those young people, in addition to sexual and reproductive health information. Yeah, that's what I can say on this. Thank you.
Absolutely. Yeah, I think all of those points are so critical. I think, you know, as Dr. Alka mentioned, when there are humanitarian crises, we know from the example of COVID, I see in the chat, one of our colleagues is talking about Tigray. We see how when there's a humanitarian crisis, that the social structure that adolescents usually depend on start to diminish or deteriorate, and the people that they could usually turn to, whether they're peers or teachers or friends, they might be separated from them, and therefore they might be more exposed to various risks. And so, you know, with that comes exposure to sexual exploitation and abuse. As Eric mentioned, greater exposure to gender-based violence, resulting in unintended pregnancy, greater barriers to accessing SRH services, as Viator mentioned. So all of that really does, you know, exacerbate the SRH needs, and often we know that SRH becomes invisibilized, right? That's what you all are saying, and resulting in what we're seeing now in many contexts, like Eric mentioned in the Philippines, with the rising rates of unintended pregnancies. Thank you for that. And, you know, related to that, Vita, you started to touch upon this, about how, you know, what the specific barriers are for, you know, or impacts on provision of SRH services to young people. So given that we know that in crisis settings, there are these specific barriers to provision of SRH services, could you share a little bit more about what those barriers might be, and how we adapt programming to meet young people's needs, young people's SRH needs in crisis settings?
Yeah, I just say that there's a problem with the lack of facilities. For instance, the facility, I can say, is a place where young people can go and chat with other young people, with peers, but also where they can get some basic information about sexual and reproductive health, but also where they can get some important services like getting HIV tested, where they can get like menstrual, that's an example, menstrual information for a young girl, where they can get like pads for free, because you see in the camp, they don't have money. They don't have the means to go to buy those important material especially for a young girl. As you know, also in the camp, of course, they are outside their usual environment, but also they make sex, they do sex. They need condom, but also they need free condoms in order to prevent unwanted pregnancies. So we need those. We need to consider, when we are like implementing activity, to consider those challenges. But also we, like for instance, we had an activity in a camp here. In that activity, it lasted a few months, and we met a group of young people, peer educator trained young people, and we considered them to implement activities in the camp. They were moving inside the camp, distribute materials. We did that because they know the language that is spoken inside the camp, but also we wanted to involve young people themselves to do the work, because they knew better than us who are not living inside the camp. Yeah, I think that we need to consider the capacity of those people who are in. For instance, you can meet those who are not trained. You need also to target them, but by firstly training them to do the work, and let them do the work because they know better. And I'm sure and assure you what have been done by our organization in that camp was very, very important. And yeah, we appreciate. Thank you.
Great, thank you so much, Vitor. Eric, I know you have quite a lot of experience working on SRH in crisis settings when it comes to service provision. Would you like to add to that?
Sure. To add to what Vitor has mentioned already, as we all know how, crisis settings how it exacerbates young people's vulnerabilities. So for the context of the Philippines, for example, in times of development, we have the Reproductive Health Law, which actually limits or restricts minor adolescents under the age of 18 from accessing SRH services. We know how in times of humanitarian crisis or settings, this is even further exacerbated. We all know that we don't even have data of how many young girls are in an evacuation center, for example, how many boys are there, how many adolescents, how many are, as what Vitor mentioned, how many would need menstrual hygiene kits, how many young people would need all vital SRH information and services, as Vitor mentioned. So yeah, now that for the COVID pandemic context, the Philippine government has imposed age-based restrictions. So they would limit adolescents below the age of 16 from going out for both essential and non-essential reasons. And as I've mentioned previously, with the number of teen pregnancies that we had in the past, we're actually quite making progress in terms of preventing repeat pregnancies. But with the age-based restrictions, with those who wanted to prevent further pregnancies, they are being restricted from going out to access family planning services. So what we would usually do, the implementing rules and regulations of the law actually only requires written parental consent from public health facilities. So for my case, as a non-government organization, we would usually provide vital SRH services regardless of setting, regardless of context, and even without parental consent. Because what we would usually say is that if we would not help these young girls prevent repeat pregnancies, we all know how critical or how ill-fated their futures would be. So yeah, basically we continuously provide. And we also know that in terms of humanitarian settings, even health providers are also affected. So that's also, that would also act as another barrier in terms of providing SRH information and services to the general public, most especially for young people. So yeah, thanks.
Absolutely. Those were both very comprehensive responses. And I think to summarize, just highlighting a few key points around the fact that in crisis settings, we know that that adolescents continue to have sex. Their SRH needs not only continue, but actually increase. And so it is really critical, as Vitor said, to actually have targeted strategies to meet their unique needs, leverage their capacities by recognizing that, you know, they not only have risks and vulnerabilities, but also contributions, capacities when supported adequately. Yes, so, you know, as Eric mentioned as well, these life-saving needs continue. And I think really thinking about the MISP, the minimum initial service package for SRH in crisis settings. We know this is the standard package of SRH in crisis settings that are life-saving and that should be prioritized, and that there is a whole toolkit, the IWAG Adolescent SRH toolkit, which outlines specific considerations for adolescents when implementing the MISP. So really, really great conversation. Thank you to you both. For the next question, I was thinking, you know, just building on what Viter said about meaningful participation, you know, maybe just if we could hear from you all, how can we, you know, really incorporate young people living in humanitarian settings into the design of programs given these unique challenges? So Viter shared some examples, but Dr. Alka, I was wondering if we could start with you for some other ideas on how we can really incorporate young people into the design of programs.
To begin with, I don't think you have to wait for a crisis to start involving them in a program. That should be part of the design, right? And you should anticipate that such situations are likely to occur. COVID has caught us sort of in an unguarded moment, and that is very clear what happens when the system is caught in such a situation. So engagement of young people should be there right from the early stage. From planning to implementation to monitoring and evaluation, we should use their existing forums. There are youth groups in the community. There are platforms which young people use, where we should go to the places which they frequent rather than expecting them to come to the, you know, institutionalized systemic service delivery points. We should leverage other programs, use the civil society organizations and NGOs which have a better reach to adolescents and youth rather than the government sector. But at the same time, and use the mediums. I must say that we must use the mediums of communication that they use. I'll just give you an example when they are not engaged, how out of sync is the system with the adolescents. I'll give an example in India. We have a national adolescent health program which has special clinics for adolescents. And these are called Yuva Maitri Kendra in Hindi, which actually means youth-friendly centers. Now, when they were opened, nobody had asked adolescents whether this is the right name for the center. So when the counselor opened the center on the first day, there was a line of 125 adolescents outside, and the counselor was very thrilled that so many people had come for counseling services. She later on came to know that they had interpreted it as a dating center. So, you know, the way adolescents see things and the way the system sees things is very different. So their involvement should be right from planning to how we name things, what services do they need, and how we monitor, and accountability should be to them rather than to the systemic, you know, authorities. That's how I see it.
Thank you so much, Dr. Alka, really highlighting that in order to be responsive to the needs of adolescents, we must engage them in the design, in the implementation, in the evaluation. Thank you so much, Dr. Alka. Anything to add from Eric or Viter on that?
Yeah, if I may add to what Dr. Alka has mentioned, so to ensure that we have meaningful youth engagement and not just tokenistic participation from young people, it's high time that we treat young people not just mere beneficiaries of programs and projects that we implement, but rather have them as partners, have them listen to them, give them a platform to speak what's on their mind, how they envision programs to run, how they think they can reach out to more young people themselves. So as what Viter mentioned earlier, they know the language, they know how it is to live in camps. So again, if we would just insist on this is what worked in the past, and it might not be the same that would work now, So it's high time that we listen and provide them with the platform, not just to speak, but also to be heard and understood. Thank you.
Super, thanks, Eric. Viter?
I think all have been said.
Okay,
And
great.
yeah, I agree of what have been said. And thank you, everyone.
Yeah, this and I think, you know, just going back to what Dr. Alka said about leveraging existing youth networks, as Eric said, ensuring that young people are part of existing platforms. I think, you know, pulling those ideas together, thinking about how we can have young people involved in whether it's technical working groups or emergency preparedness and planning, even before a crisis occurs, right? So that from the beginning, even before a crisis, we are really thinking and systems and policies and programs really consider the needs and capacities of young people. So really, really great examples. Thank you to the speakers. So I think, you know, we've already shared some really great examples. I think, you know, maybe just to hear a little bit more, we've heard some interesting examples of where things didn't work. Now, maybe just to hear from you all, you know, what are some good examples of SRH programs that have been successful at being responsive to young people's needs in these contexts? And linked to that, what are some best practices for adolescent and youth SRH programming in crisis settings? And we've already touched upon a whole bunch, but maybe we can, yeah, just hear from some more examples.
If I may start, Anushka. So back in 2011 rather, when Typhoon Washi affected southern part of the Philippines, a group of young people volunteered to assist in the government's relief and relief efforts to go and visit evacuation centers and do data gathering of how many young people are there, how many boys, how many girls are there, how many are might be pregnant, how many are in need of whatever SRH services and all that. So they volunteered themselves, they volunteered their time, and it was well appreciated because in 2012, when Typhoon Pablo then hit the country, this group of volunteer young people were already tapped by the government to assist in the response. So basically, they were asked to lead projects, they were asked to start conversations with young people, start data gathering, start knowing where young people would usually meet, where they would convene themselves. So I think that's, I mean, a success story for us of how these young people who, as I've mentioned, know the problem of the young people themselves, they would volunteer their time, their efforts and all that. And we just need to acknowledge that and give them space, give them platform so that they can excel. And now these young people are now leaders in their own fields. Some are even heads of their own organizations. They put up their own organization, which all started in an evacuation center. And now they're part of the national response. So yeah, there you go. Thanks.
That's a fantastic example. Thank you so much, Eric. And yeah, so that really, you know, highlights leveraging existing youth networks, how they were leveraged and channeled into the response in data collection and implementation, etc. Thanks so much, Eric. That's great. Any other examples from Dr. Alka or Viter?
Yeah, I can talk about two. These are examples from the non-government sector, not the government one. But what is very critical in these both examples was the programs that they implemented were highly sort of flexible. They adapted very fast to the emerging needs. So what they did was they had a computer-assisted personal information system design with screening tools also. So they collected information from adolescents about their health needs and adapted their services to that. And to a large extent, for example, health education was through, or information provision was through the platforms that the adolescents use, such as Zoom, WhatsApp, Instagram, YouTube videos. They had frequently asked questions corner where, adolescents could call helplines where adolescents could call and get information. And they also had the services through telecounseling and teleconsultation. So they adapted very quickly. But I must also say that what happens in crisis situations, particularly in India, is the first casualty. There is a hierarchy of casualties. And the first casualty usually is sexual and reproductive health. After that, adolescents, because sexual and reproductive health is not seen largely as an emergency, most of the situations. Second is adolescents, because they are seen as largely healthy age group or cohort. And within them, girls, because their health in a gender, sort of in a patriarchal society, does not have the same importance as that of boys. And that's why we need a system which takes all this into account, is highly adaptable, highly flexible, and that is possible largely through the non-government sector than the government.
Thank you so much, Dr. Alka. Great. So we have some, Victor, do you want to add to that? I see you coming off mute.
Yeah, I would like to add something. Thank you. I would like to say that when you are planning to implement any activity targeting young people in the refugee camp or emergent settings, you have to consider also other partners, especially those who are already there on the field, but also consider, for instance, here in Rwanda, we are having a ministry in charge of emergency issues. You have to also to work with them because they have either materials or other people who are already in the field who know better what is needed in the camp. So it's very important to work with others, but also this will empower the young people in the refugee camp about working with others, because we have to think of after the project is ended, and that is sustainability. You have to be prepared and prepare the young people to be able to continue activities after what have been done, what have been planned is ended. Thank you. That's what I have to say. Thank you so much.
Super, that's great. Yeah, so I think, just lifting up some of the key themes on best practices that we've heard today, it's really thinking about coordination across agencies, across government, as Viator just mentioned. Someone mentioned that, SRHR, we know that's invisible and we need to prioritize that, but we also know that adolescents have other needs, right? Maybe the mental health needs, protection needs, etc. So coordinating with other agencies to address and have multi-sectoral responses as well. You all talked about, meaningful participation. You touched upon recognizing that adolescents are not a homogeneous group. There are different subgroups that are disproportionately impacted by crisis. So thinking about their unique needs and how to reach them with platforms and information that is accessible to them. And also we want to think about the community support, the support by gatekeepers, by religious leaders, by parents, etc. So that's a really great discussion on that. Thank you. So we do have a question in the chat on what are the unique needs of boys and men in these spaces, and how can we engage them in SRHR? Any thoughts from the speakers on that?
I think there's a misconception that when we talk about SRHR, we're only talking about needs of girls. Because as we all know, most of our family planning commodities and contraceptives are female-centric. but we must instill in our young boys that a girl would not get pregnant if she would not be impregnated by a boy. And we must have them understand also the responsibilities. We must also give them space to talk about their own concerns. As what Dr. Alka has mentioned earlier, adolescence is generally seen as healthy individuals. So if we also think that these boys don't have SRHR needs, then we're somehow leaving them behind. So I think providing them with the space to talk among themselves. I mean, we can gather a group of young boys, have them discuss their concerns, and you would be surprised that, yeah, I also have, some of them would say, I also have the same concern. I also have the same problem, and I don't have anyone to talk to. So if we would give them platform to talk about these concerns, they would definitely know that they are also part of what we're pushing for in terms of advocating for young people's SRH. Thank you.
Absolutely. Anyone would like to add to that?
Yeah, I'll let you say something. Thank you. Of course, there's some need for either group boys or girls, but also we have to consider to involve everybody in that in a specific area. For instance, the problem of the menstrual pads inside the camp. Young boys also need to understand that a young girl needs to have a pad after the end of the month, because they are living together and they are growing up. They should know that girls have specific needs, and that is very critical. And that in our organization we call that men engage. We want to engage boys to support their sisters, the girls who have special needs, and help them to have solution. If not, they are not involved. As we are building families, future families, we'll meet families who are broken because the boy didn't understand that a girl has a specific need that he needs to support to have solution for that problem. Yeah, that's what I have to say. Thank you.
I think what both of you are saying is applying that really strong gender lens, right? To understand the unique and specific needs of various groups. We know that girls are disproportionately impacted, as you're saying, but that boys also may face greater risks in terms of being recruited into gangs or rebel groups or something like that. So, and we know that boys and men are also exposed to sexual violence. So just essentially taking that strong gender lens so that their unique needs are met, but they can also serve as good partners. I think what both of you said is about that information sharing and dialogue as being critical for the future. So that's really great. Thank you. So we have another question on the chat. Given the challenges you have all mentioned related to accessing services in these settings, what role do you see for the new WHO self-care guidelines and addressing some of the issues around physical access? I think this is particularly important in the context of COVID. Dr. Alka, would you like to start us off?
Yeah, sure. Yes, self-care is something which is not, unique to this pandemic. Adolescents have been sort of, because there are no specific, there were no earlier specific programs or services for them, at least in India. So adolescents are a little skeptical and worried about the judgmental attitudes of providers, and particularly in the context of SRH services, so they don't go to facilities. So they have been using self-care alternatives, for instance, buying medicines from the pharmacies and using them themselves. So that has already existed. What needs to be ensured is that these self-care interventions are proven to be safe, can be taken as per the protocol by the adolescents, and they have the requisite information, and have a backup emergency system where they can go back if they need it, if they have any complications or side effects. So as long as that whole spectrum is available, that is medications and services which they can get on their own, and they can approach a facility in times of complications or high-risk situations, then it works, self-care interventions, otherwise it doesn't. And they have the requisite information, yeah. Next.
Great. Would anyone like to quickly add to that?
Yeah, if I may.
Sorry.
Go ahead, Dr. Alka.
Just one point. The thing which comes in the way, at least in my country, is adolescent access to resources to buy these or to afford these self-care interventions.
Yeah, now that teleconsultations have been the new norm in terms of provision of SRH services, I think multi-month dispensing, for example, of commodities such as pills, condoms, can already be used as part of self-care, because this girls and boys don't need actual contact from their healthcare provider for them to take their pills or for them to have access to condom. And I think this would also address Dr. Alka's concern of in terms of financial concerns of these young people. If they wanted, say for example, they're on an injectable or they're on an implant and it's due or it's nearly expiring, and if we can assess them, if we can counsel them, if we can provide them information on how to take their pills, what to do if in case they miss their pills, I think this is a form of self-care. And if we can provide them multi-month so that they don't have to worry for the next month if where would they get their supplies and all that. So I think that's the way to go now. That's also one way of empowering our young people. Thank you.
Super, thank you so much. Really great points raised, and really thinking about how we can apply these guidelines to meeting the unique needs of adolescents, perhaps would actually support with confidentiality, privacy, but also, as Dr. Alka mentioned, ensuring that we have a strong supervision system in place for follow-up and support. So I think in the interest of time, I am going to have to hand back to Brittany. But before I do so, I just want to say a huge thank you to FP2030, Knowledge SUCCESS, and our wonderful panelists today. Thank you so much for this fantastic conversation. Thank you. Over to you, Brittany.
Thanks, Anushka. Thank you everyone for such an engaged and thoughtful discussion. I'd also like to thank our speakers for joining us. Thank you to Anushka as well for being our moderator, and to all of you for your great questions. We will be posting and sending out a recording of today's webinar. And we hope you'll join us for our next conversation on August 5th at 7 a.m. Eastern Daylight Time. And we'll conclude this set of conversations with a look at the SRH needs of young people from sexual and gender minorities. If you haven't already done so, you can register at the link that will be put in the chat. And we also hope that you'll follow FP2030 and Knowledge SUCCESS at the websites and handles that you see on the screen. Thank you again, everyone. Thank you, speakers and our moderator, for joining us today. And thank you all for such a great conversation. The hour really flew by, and we will see you next time on August 5th. Thanks.